No.
Okay, it's there. I just want to make, was it loading? 69 slides. You do not have 69 minutes.
No. Never.
20, 25, 20.
Yeah.
Oh, should I introduce you?
No, that's fine. Okay. Now we've been talking a lot about sympathetic blocks, and I would like to show you how to do these sympathetic blocks, and I would like to draw your attention to the fact that it is very important what substance you are using, what concentration you are using, and what amount of substance you are using, because it has a great impact on your results. Now, why do we do interventional pain management? Actually, usually people that we, or patients that we get to see, they present with a lot of different drugs, and all these drugs have side effects, like they make the patient sleepy, and it's no use being reduced in the pain intensity, but sleeping all day long. So the patient doesn't have much of a benefit out of that. Then you have other problems like disorientation or nausea um, or obstipation that we want to reduce. And we can do that if we do interventional pain management, and we can thus improve the quality of life. Now, for sympathetic blocks, you've heard already that we have the autonomic nervous system. It's divided into the sympathetic and the parasympathetic nervous system. And we find the sympathetic nervous system centrally and extravertebrally. And this is what I'm going to talk about mainly. Now, what came up first was intravenous sympathetic blocks. They are used for, or have been used for, sympathetically maintain pain of the extremities. You put on a blood pressure cuff and inject a substance into the extremity that's affected. And the substance that you are injecting depletes the norepinephrine reservoirs and inhibits the reuptake of norepinephrine. Now, this is what you see. This is a patient with a CRPS on the left hand, and there we put the cuff, and now we're injecting the substance. The problem is, once you inject the substance and you release all the norepinephrine, the pain intensity increases a lot. And we didn't have too good results, so we just did not do that anymore. Now, if you do the central part of the sympathetic nervous system, you can do either spinal blocks or epidural blocks, which you can do in the cervical part as well as in the thoracic part or in the lumbar part. We usually do not do caudal blocks. Now, for the extravertebral sympathetic nervous system, you can do blocks on the cervical sympathetic, which you can see right here. These are the sympathetic change on the left side and the right side. We have different ganglions. This is the superior cervical ganglion. You have the medial one and the lower one. And the lower cervical ganglion often fuses with the first thoracic ganglion, which is right down here, to form the cervicothoracic ganglion, which we call the stellate ganglion. Now, the problem with the blocks is that we do not have just the sympathetic chain. We have the carotid artery, we have large veins, we have the lungs, and the ductus thoracicus, which we can accidentally perforate. Now, how do we do cervical ganglion blocks? If you look at the upper, the superior cervical ganglion, you usually block that in patients with facial pain or with trigeminal neuralgia or ocular pain. And other pain syndromes of the upper extremity, you can also use that for Raynaud's syndrome, for example. And what can happen due to the anatomy of the region where the ganglion sits is that you puncture the internal carotid artery or the vagal nerve. Now, this is something we do not want. We usually, in Hamburg, where I work at, when we do the upper cervical ganglion blocks, we do the oral block. Now, you need this thing, which is a special guide for the needle, to reach the upper cervical ganglion, which is sitting back there. You have a spacer. This thing stops your needle from going much further into the soft tissues. And then you have the guide for the needle, which you insert back here. Now, you have your patient sit, do local anesthesia of the mouth, and poke the needle right back into the pharynx. It sounds very weird, but we use very, very tiny needles. So it's just like having a, how do you call it? Is it fishbone? Yeah, or a dental procedure. So it doesn't really hurt. Now, as you can see from the anatomy, what I told you before, this is the superior cervical ganglion. This is where the artery sits, and this is where the vagal nerve sits. And if you do not have the right direction of your needle, you might as well poke into one of these. This is what we don't want. So you need to do aspiration tests, which do not prevent you from injecting substances into the artery, but it gives you some kind of aid. Now, the medial ganglion we usually do not block because it's very difficult to reach, so that's why I'm moving on to the inferior ganglion, the stellate ganglion. This is a procedure that's been performed very often, and you can use it for cervical, facial headache, or pain of the upper extremity. There have been a lot of papers published on sympathetically maintained pain of the lower extremity, where the authors also did stellate ganglion blocks for the lower extremities and did obtain quite good results. What we started doing recently is that in acute hearing loss with tinnitus that doesn't respond to more conservative procedures, or where the ENT department doesn't offer any other treatment, we do the stellate blocks too, and sometimes we are able to reduce the amount of tinnitus. Now, every procedure that you do has its complications. Now, blocking close to the carotid artery, it's possible that you put your needle into the artery, or do epidural or spinal anesthesia, or block the brachial plexus. But this is where thermography comes into the game, and we can see what is happening if we do it properly. This is my colleague. He had to lie down there for showing how to put the patient. He is lying on a pillow under his shoulders and is retracting his head, so I can reach the stellate ganglion much more easily. Here you have the clavicle, the sternocleidomastoid muscle. This is where the artery is at, and right medial of the artery is where I try to insert the needle. You have to put the needle straight down, push the artery a little with your fingers to the side so you don't poke the needle in there, and try to establish bony contact with the 6th or 7th cervical vertebra. And then you have to retract the needle for like a millimeter, and then you inject your agent. This is what you get to see if a proper procedure is performed. What we do is we always use ropivacaine, 1%, 10 milliliters, because we are able to compare the results, what's happening when we use this agent, this concentration, and this amount. In Germany, a lot of people prefer to use procaine or lidocaine because it's not very long acting drugs. Um, and they are always afraid that if they have some symptoms that they don't want, like Horner's syndrome or hoarseness, that would wear off more rapidly if they use a short-acting agent. Also, they're afraid of convulsions in case they put the local anesthetic into the carotid artery. Now this is what you see in the face after a stellate block, and this is very typical that you have half of the face light up that much, and here you can see the band-aid that we put on the puncture site, and you have a very significant increase in the temperature. Also, you can see that the lady's ear is also hyperradiating. So just to say that if you have problems or pain in that area and you suspect sympathetically maintained pain, you can also try to do these kind of blocks. Now, being at a university hospital, we have a lot of students and trainees, and a lot of patients who come to us because nobody else could help them. If you do the procedure and have pictures like this, it's very easy to explain to the patient what is going on. He or she is able to see that there's results of the procedure, even if he or she does not experience pain alleviation right away. But they see something is happening and they stick to the procedure even if it takes a longer time. Now, other patients, like this one, we had a student do the stellate block the first time, and the patient kept saying, "I'm not noticing anything." Now, what we saw was, this is the initial picture. He had a CRPS of the left hand, and he had received 5 or 10 blocks before this one. And what we saw was that the C6 and C7 dermatome was lighting up instead of the whole hand warming up. So we could explain to the patient and also to the student, who was very disappointed that he couldn't do it the right way, what was going on, and that he just didn't meet the right anatomic structure. Now, if you go further down, you can do thoracic sympathectomy. That was what Dr. Brioche was just showing us. We usually apply the endoscopic sympathectomy, where you can see the sympathetic chain and you just cut it off. You can do it in any pain, sympathetically maintained pain of the upper extremity or the face and the neck. Now, what we have developed is a new procedure. It's a CT-guided procedure. It's a continuous procedure, and I'm going to show you why this continuous procedure makes a big difference. Now, what we do, you see our patient lying here. Before this block, he's raped, and the skin is prepared. And what we do is, this is the T2 segment. And here you can see a metal marker. This is the back of the patient, and this is the ventral side. And we measure the distance from the skin to where we expect the sympathetic chain to be. Then we insert a needle right up to where we get into danger of perforating the lung, and insert 40 milliliters of water to move the lung from the vertebra, so we get this much of space. And then we can advance the needle, walk it further down to where we, like here would be the thoracic sympathetic chain, where we expect the chain to be, and insert a little catheter. You can see this reflection here, which is the metal catheter coming out of the needle. Then we do subcutaneous tunneling, and this here you can see this is the catheter lying here. And we fix it with band-aids and saw it, and then we insert a little bit of contrast media to confirm the position of the catheter tip. And if we inject 5 milliliters of local anesthetic and contrast dye, we usually get to see this picture. Now, if this shows up, we are sure that we are in the right position, and connect a pump to the catheter and do continuous infusion of 0.2% ropivacaine, 10 milliliters an hour, for however long the patient needs it. What we can see after this procedure, this lady has been treated for 30 days with the catheter. And you've seen that picture before, but you can see that during the treatment, her left shoulder is coming up a little, and in thermography you can also see that the left hand, the perfusion of the left hand is much better because it's hyperradiating. Now, what did we do? We went through the charts and CT scans of our patients that we treated with this procedure between 2002 and 2007. There was 293 patients, 69 of them were suffering from CRPS. All of these patients had been seeing doctors before. They had been on medication, and nothing really helped them. And they didn't have another choice than trying this procedure because there was nothing more anybody could offer to them. They were aged about 60, the median age was 63 years, ranging from 14 to 91. And with the CRPS patients, you can see that their median age was a little lower than the average population. And what we were able to achieve was that the initial pain intensity of 8 came down to about 2. Oops, this is the median. Came down to about 2, not in all of the patients, but in quite in about 84% of the patients we could decrease pain intensity. And also in CRPS, we had the same results with even a better outcome. Now, the time we needed to achieve a 50% reduction in pain intensity was 202 hours. So this is what I was saying initially. It's the drug you choose. If you have a very short-lasting drug and you do sympathetic blocks, you might not be able to overcome pain. Whereas if you use a longer-lasting drug, we don't have a drug that lasts for 202 hours, I know that. But if you use a drug that lasts a little longer, you might be able to reduce the pain much more easily. And if you do the continuous infusion, it's even better than that. And what we could see in the CRPS patients is that they took even more time. I'd like to show you Julia. Julia had a trauma, and she'd been on paracetamol, and she was immobilized in a splint. And this picture you've seen before. And this is what she looked like before treatment, or her hands. The right hand is the affected hand. This was the maximum she could open her hand, and this was the maximum she could close her hand. After 16 days of continuous infusion, we got hair. She could make a fist. That was the first result that she experienced herself. Pain had gone down after 10 days, but it was so important to have the thermographic images because she kept saying after 2 days, well, nothing's happening, and I don't believe in the procedure you're doing. And